Good afternoon, everyone. I've got the enviable task of actually trying to keep this lot in order and indeed to ask some of your questions. But really important is that if you actually want to ask anything that you haven't sort of written on a card or something new, please wave at me and we'll get a microphone to you. As Anu said, I'm Yvonne Franks from the London region, Patient Experience and Patient Public Voice Lead. And I would like to hugely thank all of the speakers that we've heard today. But of course, we didn't get to ask them any questions. So this is our chance, really. So I'd like to start by asking them all to introduce themselves again, in case any of you missed it earlier.
I'm Ben. I'm an opinion pollster.
I'm David McNally. I'm Head of Experience of Care with NHS England.
I'm Jocelyn Cornwell and I run a charity.
I'm Annie Singh and I'm Director of Patient and Public Participation and Insight at NHS England.
And I'm Dan Wellings, Head of Insight and Feedback, NHS England.
Okay, so I'm... I'm going to get through as many of these as I can, but as I say, please wave at me if you have got something to say. So the first question is, why is there such a disconnect between NHS England's focus on using feedback and CCG's focus on collecting feedback, like sequin response rates in emergency departments, UCCs, that sort of thing? Who'd like this one?
I'm fine. Yeah, I mean, it's a question of what it feels like on the ground, and it does feel like there's a disconnect, and I think it's simply because we use data for a whole range of services, a whole range of functions at the moment. So the stuff that Dan was talking about earlier, and I'm sure he'll want to pick up something on this question, around the direction of travel, is we want to much closer align the hunger for the right kind of voices, stories, data, and kind of ways of collecting it out there in the regions and in providers and kind of different footprints with what we're going to do with it at a national level. So the disconnect, I think, mainly is historic. So often we use data for kind of historic purposes, and maybe that data request lingers on, and maybe the commissioning journey is now focusing on something else. But I think the purpose of events like today is to help us get that story straight and bring some of those things back together.
Anybody else? Dan?
Yeah, I mean, I think it's partly a response rate question, isn't it? I think, which is some of the early work on FFT really focused on getting the program up and going, and around getting response rates and making sure that people were putting the systems in place. And I think it'd be interesting to hear from people who asked that question about what the conversation is with the CCG, because I think one of the things that we've been working with David's team in Patient Experience and Neil Churchill is, how do we get the conversation on improvement? How do you get it on not just how many forms do we fill in, how many responses have we got, how many people have we heard from, but start to shift that conversation to what have you done with that? So I'd be really welcome to try and pick up with people who are asking that question on what that conversation is like at the moment. And it might be something we need to do as part of that insight network about how do we get the right conversation going on between the two organisations.
Would anyone like to own up to that question, or indeed for... gentleman at the back.
Hi, I'm Matthew from Bristol Community Health. The conversation with our CCG at the moment in terms of our quality schedule is very much still about achieving a response rate target in our urgent care centre and minor injury units, and also picking up response rates in some of our other community services, which is actually really unhelpful. So it's been really great today to hear so much about using the data. But that's difficult on the ground as a provider when your commission is still focusing on collecting huge samples and maybe not having a conversation with us about doing stuff with it.
Yeah, I mean, again, it would be very useful to pick up, and Ruth Hudson in our team has been a specialist within this area as well in terms of community. It was one of the ones that was introduced later after acute and A&E, and I think it seems that there's quite an interesting journey, as it were, in terms of what the first year's about, what the second year's about, and then where do you take it from there. But it'd be very helpful to pick up.
David?
Yes, I think what you're highlighting partly is just the huge difference in terms of where we've been historically. So we all know that where the real focus has been, largely until now, on improving people's experience of care has been in the provider sector. And I think commissioners are playing catch-up, generally, you might say. You've heard from some examples today, so Rob from Dudley has described a very different story to the one that you just told us. So we know it's beginning to happen. We've just run a development programme we're just coming to the end of a development programme with 9 CCGs who are in slightly different places, but they're all very much wanting to get onto the improvement agenda in the way that we're talking about. So I think it is beginning to change. I think the thing that we need to begin to think about is how can we make that happen on a much larger scale.
Thank you. Choose another one now. The question is, has there been any more thoughts, discussions regarding tracking and monitoring a patient's experience across multiple touch points? Who'd like that one?
Yes. I mean, I think it partly reflects the challenge that we talked about earlier on, that without becoming too technical, one of the things that we do is we draw the sample from the actual service. So when we do the GP patient survey, we draw it from a practice list. But we have no idea from that data whether someone's in social care, whether they're an inpatient, whether they're receiving other services. So we're slightly hamstrung by how we do that. One of the most interesting things, hopefully, in the vanguards and in some of the other areas is how can you do that at a local level? So we know, as I said before, I think I touched on this, that transitions are always the most challenging moments. I remember very vividly in terms of a piece of ethnography that was done with children moving into adult services. They felt they'd been thrown out of the NHS. So I think, yes, lots of thought, lots of work. There's other pieces of work at NHS England and beyond which we need to make sure that are right around data, what we can do with data, what we can understand in the background, but we need to get there. I think it's a real key area.
Anybody else want to comment on that one? Oh, several.
Just a very brief thought, which is back to CCGs. I think the unique position that CCGs are in, of course, is that they should be able to see the whole picture. They're commissioning across a whole range of providers. We wouldn't expect individual providers necessarily to be able to have that picture. And for me, it partly goes back to what Ben was talking about in terms of there is an opportunity here, whilst we haven't quite cracked the question of how do you do it through a survey and the rest of it, there is a qualitative way of approaching this, which is for CCGs, as the commissioners of services across pathways, to sit down with those patients and understand what that experience is. And I don't think we really do that at the moment. Isn't that the qualitative aspect of it isn't terribly difficult to do. We just don't do it.
Yeah, no, I was just going to make a point about the focus of the question, really. It's an interesting phrased question because it starts with data and it starts with data collection. And one of the big shifts we're trying to land is around person-centred care. And actually the idea of the patient knowing their own story, being right there at the heart of their own care, which does span a number of different initiatives, a number of different teams across the health service. And I think the data lens that we're applying to the problem here is kind of endemic of a bigger problem in that we haven't quite got patient-centred care right yet. And there are developments around personal health records and electronic records and as Dan says, how we use data differently, that will help. But I think that fundamental repositioning of placing the patient at the centre of their care will give us a lot of different narratives and a lot of kind of that more holistic picture at a point, not too far off, but a kind of point in time.
I mean, I think the work we've been doing, the ethnographic work that I showed you some clips of, obviously shows this problem of people going to multiple institutions with different problems. But at a geographic level, collecting through your GPs, collecting a sample of people who you know are likely to be having multiple touch points and building something around them it isn't rocket science, and you will get loads of stuff. How you process that inside your silos, of course, is a huge challenge. I mean, it's funny you talking about multiple touch points. There's one thing that we do for the media industry where we measure everything you ever look at on your television set, laptop, iPad, phone, all the phones in your family, all the games. It's and to take all of that data just from 5,000 people is incredibly complicated. So, trying to do this in a very scientific way would be challenging. There must be something though about gradually when the patient GP survey goes online, reaching out to patients in a particular area and having quick filters through multiple contacts. I mean, it can all be done, and I'm sure somebody will try it. But trying to create one of the challenges you have is a big complex system. Many of the things you've had have been top down and imposed, partly just to get people to do things and all do things. And of course, not everybody's, and that's sometimes the cart is before the horse. But it can all be done. And I think what's interesting today, because I'm now a boring administrator who looks at spreadsheets rather than a proper researcher anymore, it's really interesting to come back and just see how much this sector has moved in the last 5 to 10 years on this stuff. Because in the past, it was just stuff that was, you did more surveys than anybody and paid absolutely no attention to them. Things are changing.
He's changed his mind. Opening that to the floor, is anyone trying to do that with their own systems locally? Okay. So, next question. Are any companies close to developing software capable of theming the verbatim comments from the mandatory FFT follow-up question?
There's a whole. I'm not offering to do it, but I can if you want. But there are various solutions. So for Barclays Bank, if you write something on the interweb about Barclays Bank that you hate them, if you write them a letter, if you email them, it all gets synthesized 24/7 and is processed into daily reports for their management. So this software, these algorithms, these softwares do exist. They're becoming more and more sophisticated all the time. For God's sake, there's Google Translate, which will, you can hold it up to something in a museum in France and it will read it in English. So it can all be done.
Yeah, I mean, there's a lot. We're approached a lot on this, and some of them are better than others. And it's about some of them are ones that you wouldn't want to be using at the moment. They're not good on sarcasm. Positive, negative, positive is one of the ones I saw where it was clearly a sarcastic comment that's come out as an absolutely fantastic thing when it was kind of analysed. There's lots of work Demos and others are doing around this. We need to get there. But the only thing I'd say is it's back to what do we want it for? Because actually, what you can sometimes do with comments is make them overly reductionist. So you get back to a point where it says the theme on the comments tends to be around communication. Now, that's useful at an organisational level, but I think what we found from FFT is the granularity of the feedback, which really helps you. So I think Beth in our team is working with ESRC, and I think Lancaster did in the session before, around how do you start to do this, and we've got to look into it, but it's being clear what we want it for. Sometimes the results of it can feel a little bit, and what do we do?
Okay, I'll do one more question and then I'm going to ask if any of you have got any not on my list. Okay, so how can we increase staff confidence in getting feedback from patients? Sometimes we are so focused on the data and metrics that at senior levels this is sometimes the conversation driver.
Thank you. How do you increase staff confidence? I think by starting from a position where you recognise that it's daunting to get feedback from your own patients about your own service, and starting from a position where you understand, as I think I said earlier, that most people expect to get negative feedback. They don't expect to get positive feedback. So, I'm afraid to say that I think the only answer is to get some people to do it. There's a good study that was done in Scotland that was a controlled study that looked at teams working in cancer, and the case examples were actually taken through a process of co-designing and changes in the service with patients, and the other team were just given the feedback and told to get on with it. And basically they measured the before and after of staff anxiety about working with patients and hearing feedback. The teams that actually engaged with patients directly, their confidence was immense once they'd done it. The team that had the feedback, numerically and even qualitative data, but hadn't engaged with the patients, were still saying, I really don't want to do this and I don't think it adds value. So I think you have to start with the willing, find people who want to do this, get some examples going in the organisation, and then build out from there. And particularly, I would say, get some doctors on board. And because there's such a powerful influence on the people all around them. And in my experience, there's always doctors in every organisation who are really interested in their patients' experience, but they're not necessarily interested in things like food that they can't do anything about. They're interested in hearing about their own patients' experience of their own service and aspects of it that interest them. So you really have to work with them, get them going, get them doing patient shadowing, and pretty much then you're motoring, because they will influence their colleagues.
Anyone? Anna?
And this is a kind of personal reflection, really. What I found that works really well in my provider trust is actually being really clear around what we are using the feedback for and what we are gathering and seeking to improve levels of feedback for. So sometimes both staff and patients might feel anxious if they don't actually know where it's going to dock in. And I chair the quality committee, and at every committee we have a conversation around how FFT has made a real difference to the kind of conversations that are happening at ward level. So how we use FFT is almost as a kind of opener for conversations around improvements, how we empower some of those staff or even patients and their families to take a greater role in that. And I think that that cultural shift around landing the narrative of why we are seeking feedback is really important, and it helps you then improve uptake, and it helps people build their appetite for kind of different conversations around quality and improvement.
Is there anyone from the floor who'd like to impart some good practice in this regard? Anybody cracked it? Okay then. Anyone got another question? Thank you. Oh, several. Marvellous.
Hi, it's Liz Owen here from the Care Quality Commission. I'm Head of Surveys and Qualitative Intelligence. It's less of a question and more of a comment about the question about text analytics that came up earlier on. So we are just buying some text analytics software to use. We get the most giant quantity of text-based data at CQC. If you imagine we regulate 55,000 organisations, if we got one bit of information on each of you a month, that would be quite a lot. We get quite a lot more than one bit. So that's one of the big challenges for me in my role. And I'm wondering whether this is a candidate for a subgroup of the network, so that we start to bring together people who are working on this similar challenge across organisations to share learning. As Dan said, there's quite a lot of people in the academic world looking at this, and I feel like if we look at it together, we're going to get a lot further, a lot quicker.
Sorry, there's another question at the front here. Okay, hold on. Yep.
People won't hear you. Hold on.
It was just a little bit feedback you were just asking for then. When you said about getting people involved and involve the doctors, we don't have a specific champion on maternity ward. Every member of staff is expected as part of a productive ward to participate in this. And they were asked, when we started it, I said they were on the desk and people didn't take them. So we asked every member of staff what they thought and how we could improve it. So we don't have specific champions because we feel then it's like, well, it's not my job, it's hers. That's why we do it. That's why we have everybody involved. And I feel that was part of our success as well. Okay.
I'm wondering if they're doing feedback from patients, a lot of patients are different. They've got learning disability or not. They have to figure what type of format they can use. What to do feedback from patients. Because it will me a bit on my mobile phone. But other people it's different. You've got to figure what type of format they can use to get feedback from people.
Yeah, so, I mean, I think it was always the challenge with one question for everyone, you know, in terms of the Friends and Family Test in its original incarnation. And it's something that we, as a team, and Ruth Hudson, I would just thank at this point, because did huge amounts of work around how do we get this to work for different audiences. And certainly in our first set of guidance, I don't think we were as happy as we wanted to be in terms of making it accessible and making it available in different ways, in different formats, for different people to be able to feed back. And even a conversation I just had before with someone who has Parkinson's, who was being asked to give written feedback and made the quite reasonable point of you won't be able to read it. I think we're still not there about having the right methods for the right people at the right time. I think we're a long way ahead of where we were. Certainly as a team, I think we feel more comfortable than where we probably did a year, 2 years ago. And I think this is the challenge, frankly, of national initiatives, which is why we're so clear on what we can do and what we hope is being done and what we can support is being done in local areas. You know, we know a national survey will exclude some people. We just know that. But we hope that some of the techniques are being put in place. In the commissioning insight work I did before, we talked about how do you, from groups where we don't hear from very often, or we call hard to reach, how do you train peer researchers up? Or how do you get other ways of getting the feedback in? So there isn't a perfect method. There's definitely been progress, but a lot more to do, I think.
I think there's a difference between collecting the data that is required of organisations by NHS England or by their commissioners, and collecting information that is for your own organisation's purpose to learn and improve. And I think there are examples in different parts of the country of provider trusts that have actually worked very hard on trying to get feedback from people with learning disabilities using other methods. And the one I've heard about most recently is at the Royal Berkshire Hospital, where there are people, where there's a learning coordinator, a person whose responsibility is to improve the experience of people with learning disabilities inside the hospital. And what she's done is she's worked with one of the local organisations and trained up 3 people with learning difficulties to interview patients when they come in who have learning difficulties about their experience. And as a result of that process, they've learned a tremendous amount about the changes that they need to make to serve that patient community better. So I think it's important to remember all the time that there are multiple things that can be done locally for the purposes of learning and improvement that are different from and worth doing what's required. It's different from what's required of you by NHS England.
Yeah, and I can think of a really good project in the FFT Pathfinders, which was LD-based as well, which used users to ask the questions too. So it's all out there. Have I got one more? One more. Okay. So, Hello. Oh, go ahead.
Really quick one. Is devolution a game changer or just slight distractions from this agenda?
We don't know yet. So I think on the devolution thing, actually, in some respects, it further pushes that need for national and local data for exactly the reasons that Jocelyn's talked about, because one of the things we're struggling with, which is slightly different from your question, but I think is relevant in some ways, is that as we move towards different models of care, as we move to PACS or different ways of providing primary care, how do we keep an eye on what's working well and what's not working well, and you don't move to the kind of dreaded postcode lottery of knowing that care in one area is better or worse than another. So I think I would add to your challenge on the devolution the challenge of new models of care, which I think is something we're just starting to try and understand within the context of the National Survey Programme. In many respects, it makes the data that's comparable data, whether it's PROMS, whether it's the inpatient survey, even more important because it allows us to track whether that's having any impact on care.
It's a very good question. I think just to give you an example of a meeting I was sat in yesterday in Greater Manchester, so we are doing some work with them around carer experience, and what they're really interested in as part of what they're doing on devolution in Greater Manchester is thinking about how do we get to a point where we've got a much more consistent experience for carers, which may then be nuanced within each locality. So there's a thought that there's a framework which gives us a consistent set of expectations that we set out to meet, and then we may then have some variation in terms of what happens on the ground. And the way we're doing that is that we've done some work nationally with the Association of Directors of Adult Social Services to look at what's a much more integrated approach look like, and they're going to use that as a starting point together with what carers organisations have said about what their expectations would be, and they're looking then to get each of the localities to sign up to that. And this is all being done through their governance structures. It's all being done through their overarching governing commissioning board, and so on. So there are real opportunities, I think, with some of these things that we might not realise, but if we grasp those opportunities, we can really bring together the best of what we've begun to identify works nationally with an approach at a local level that means things might get significantly improved rather than ending up with the kind of result that Dan was just referring to.
Right, Gillian's hand signals tell me that we're out of time. We've got one more from the floor, or are we out of time? If it's a quickie.
It's a very quick one, Tim Benson. I'm just interested, the last couple of questions have been talking about integration and devolution and changes in the way. How's things going to change over the next 12 months?
So, I was going to say before I was cut off at the last question, as usual, the kind of devolution agenda will be the difference between the idea and the reality. So, the potential for integration, for devolution, for that kind of big picture thinking to really be game changing is immense, because it asks us to look at not conditions, not settings, but to look at populations and to look at people, to build in a very new way infrastructure that we've never had before. So we're all trying to nudge things and change things, whereas devolution, the new care models, will be building the infrastructure we need to look at people's whole life journeys and to look at their holistic needs, which is all great. But I think your question, Tim, around the time scale, obviously we can't get there that quickly, but the big news on this is a mixed audience to be saying this to, but the STPs, despite the horrific timeline which we've been given to get these done, are a massive opportunity to actually bring that forward and to look at that integration, that holistic need, quite quickly bring it forward kind of this side of the summer and start that thinking. So we're in a really good place next year to start allocating investment and prioritising according to that. So whilst it's not ideal, it does give us that kind of hurry up, we need it now impetus.
Okay, that really is it. Thanks a million for all of your questions. For those that I haven't had a chance to ask on your behalf, we're going to ask the panel and write that down, it's my understanding. So please join me in thanking the panel this afternoon.